Um, Terrific. My name is Dr. Laura Vlegels, and I serve as the supervising child and adolescent psychiatrist for the County of San Diego. I'm so grateful to be here today, and seeing the names of the people come into the chat it's just so nice to see so many of my colleagues and peers. It's nice to know I'm presenting to a friendly audience. Today, I'm going to be doing an overview of psychotropic medication in youth, with a focus on legislative updates and best practices. So to start, I think we can collectively agree that the kids that we work with often face big challenges. These children deserve the best treatments and supports that we have, and that treatments need to be monitored for safety and effectiveness. In child psychiatry, we have a literature base that's emerging on an ongoing basis for psychopharmacologic interventions for many of the disorders that kids face. But the vast majority of literature is for monotherapy. We know there's much less evidence supporting the efficacy of medication combinations, but we frequently reach to medication combinations for a variety of reasons. So kids who have complex comorbid presentations, to enhance the outcome for treatment refractory or partially responsive patients, to manage the side effects of an effective agent. And of course, there are also symptom profiles that kids suffer from that lead to functional impairment, for which we know medications can be helpful. So struggles with aggression, tantrums, sleep difficulty, and impulsivity. Pulling data from our own organization, ACAP, we know that a large percentage of children have some mental health disturbance, and about 5 to 9% have extreme functional impairment. And we know that despite the availability of effective treatments, delays in care are the rule rather than the exception. And that only about 1/5 of kids with mental disorders are adequately identified and receive mental health services. We also know that the longer the lag time between symptom onset and treatment, the more difficulty and costly illness is to treat. And if you look at the major mental illnesses, most typically have an age of onset under the age of 20. And the consequences are serious. We know that suicide is now the second leading cause of death for youth age 15 to 24. We know that youth with mental illness have the highest school dropout rate of any disability group. And if you look at the cohort of kids in juvenile detention, a majority will have at least one mental illness. So what I'd like to do in this presentation is kind of rewind the clock to the 90s, early 2000s, and start to tell a little bit of a story about how our sphere changed, as did child welfare, and where the legislative and oversight efforts came from. So this is a Time magazine cover from August of 2002, in which this idea that young kids could have bipolar disorder was discussed. And we know that between the mid-90s, 1994 and 2004, there was actually a 40-fold increase in the diagnosis of bipolar disorder in youth coming from the outpatient settings. And what happened during that time was that different groups, different thought leaders in our profession worked to put together their own modified diagnostic criteria for research studies. So National Institute of Mental Health opted to stick with the DSM-4 criteria for mania. Dr. Geller at Washington University considered mania to be an elevated or expansive or grandiose mood, and allowed for cycling within a day, which they called ultradian cycling, and found that the average length of a mood episode was greater than 2 years. In Massachusetts General Hospital, Dr. Biederman defined mania differently still as non-episodic persistent irritability. And of course, with different thought leaders kind of redefining mania, it had implications for classification, prevalence, treatment, and prognosis. So in that same time window I just brought forward, 1994 to 2004, we also saw kind of the birth of the atypical antipsychotic medications. Risperidol was FDA approved in 1993, Zyprexa in 96, Seroquel in 97, and then in the 2000s came Geodon, Abilify, and others. And of course, these medications were initially marketed as kind of being this solution to problematic old school antipsychotic medications, and were marketed as having fewer side effects. And we now know, of course, that while incidence of tardive dyskinesia and movement disorders might be less with this group of medications, there are other side effect profiles that are equally or perhaps even more concerning. In 2013, the DSM-5 was published, and there were several major changes that impacted diagnosis of kids. A couple of which I think are important for us to discuss that are germane to some of what I'll be talking about shortly. First, there was a couple of new diagnoses, of which DMDD was one. And then there were age-related diagnostic criteria changes to other disorders. So in the wake of the bipolar quote unquote epidemic, the DSM-5 kind of categorized persistent irritability with the as disruptive mood dysregulation disorder. So this was a brand new diagnosis, never previously seen before. And then there were some major changes to the PTSD diagnosis for kids. So first of all, PTSD moved from the anxiety umbrella over to trauma and stressor-related disorders. The arousal cluster now included irritability, anger outbursts, and reckless behaviors, and modifications were made for the diagnosis of young children. And if you look at criteria A for PTSD, in addition to PTSD stemming from an event that a person themselves experiences or witnessed, now they added that the traumatic event could occur to others, especially primary caregivers, or even learning that a traumatic event occurred to a parent or caregiving figure. And the new and modified criteria were in part derived from studies about children who had lost a parent or caregiver through death, abandonment, foster care placement. If we look at the child welfare population, we see that there are disproportionately high rates of social, emotional, behavioral, and mental health challenges that result from maltreatment and trauma. And from our own ACAP child welfare practice parameters, we know that up to 80% of CWS involved youth have behavioral, developmental, emotional concerns that might require mental health treatment. Child welfare over the period of time that I've been discussing also started to focus more on the impacts of trauma. The National Child Traumatic Stress Network noted that foster children with significant trauma history might display overlapping or false positive symptoms that might mimic mental illnesses, such as bipolar disorder, ADHD, ODD, and other diagnoses. And noted that trauma-related behaviors and symptoms could result in misdiagnosis of mental health diagnoses, even by the most experienced clinicians. So there was really this birth of an idea that kids with a trauma history will have trauma symptoms, and an idea that just because there are externalizing or internalizing symptoms, it may not mean that they have a classifiable mental illness. We know that research on safe and appropriate pediatric use of psychotropic medications lags behind prescribing trends. And we know that research suggests that comprehensive, collaborative, and interdisciplinary mental health treatments, those approaches are more effective. And ACAP has a number of practice parameters that are germane to the topics I'm discussing today, including practice parameters for kids in child welfare, kids prescribed psychotropic medication, kids in detention and correctional facilities. And before I move forward and start talking about federal and state oversight, legislative changes, I do want to note that while I may not mention it kind of in each and every, with each and every slide, these ACAP practice parameters were regularly reviewed by federal, state, and local organizations in working towards efforts towards safe prescribing, oversight, and monitoring. So if we start looking at the data around child welfare, medication usage for the kids in the child welfare population, there were a number of studies done during that same time period I've been discussing, in which we found that youth in foster care were prescribed psychotropic medications at rates vastly higher than youth in the general population. A 2010 analysis showed that kids in foster care were getting psychotropic medications prescribed at a rate of approximately 9%, compared to 1.5% of Medicaid-insured youth who were not in foster care, compared to only 0.75% of privately insured youth. And even when studies controlled for diagnostic and socio-demographic factors, we know that kids in foster care were prescribed antipsychotic medications at twice the rate of other Medicaid-insured kids. And so with these studies became the first efforts towards federal investigation. So the US Government Accountability Office presented a paper in 2011 that reviewed prescribing trends from 2008. And they reviewed prescribing practices to foster kids in 5 states. And they used the best principles from ACAP as a guide for what optimal care should look like. And this federal organization identified a series of concerns, including kids being prescribed multiple concurrent medications, kids receiving medications at doses higher than what the FDA approved, and provision of medications to kids under the age of 1. The Office of the Inspector General published a paper in 2015. It reviewed provision of medications, specifically second-generation antipsychotics, prescribed to kids in 2011. And they had board-certified child and adolescent psychiatrists review the medical records related to the cases identified. And they identified quality of care concerns in 67% of the claims reviewed. Most frequently poor monitoring, but also concerns about the care provided being the wrong treatment, kids being on too many medications, taking medications too long, at the wrong dose, the kids were too young, or that the kids had side effects. And while this energy is coming from the federal level, our entities within our state started to take a closer look at care provided to foster kids. And this is a screenshot from a newspaper article series from the San Jose Mercury News. And I bring this to you specifically because this article series is frequently referenced when legislation was being proposed to manage what this perceived problem. And this is a 5-part newspaper series that really went on to win a series of awards, and was really taken to be an excellent piece of investigative research, highlighting this problem. And in this newspaper article, they noted that foster kids in California were prescribed psychotropic medications at 3.5 times the rate of kids, just the general population of kids in the United States. And they also looked at the fiscal impact. So they noted that psychotropic medications accounted for 72% of the medication spending for foster youth in the decade leading up to their report, and that the antipsychotic medications was a large proportion of the spending. This news series also highlighted concerns about pharmaceutical influence with prescribers to kids in the foster care system. They noted that $14 million had gone to physicians who prescribe drugs in the foster care system, that the physicians who serve foster youth received more than twice as much as the typical California doctor in payments from pharma, and that frequent prescribers in 2013 collected almost 4 times that of lower prescribers. And so with this constellation of, kind of a spotlight from the feds and the state, oversight efforts started to emerge. And if you look at the history before 2005, there were really few efforts to monitor antipsychotic medication and to promote best practices. But between 2005 and 2012, these initiatives really proliferated. And by 2013, 45 of 50 states had employed at least one strategy for oversight. And by 2015, 31 of the 50 states required a prior authorization for antipsychotic medication for Medicaid-funded youth. Now, despite there being this kind of rapid rollout of these monitoring and oversight strategies, little was really known about the effectiveness of these programs on targeted outcomes, and little was known about the potential unintended consequences. And unintended consequences could include inability to obtain the antipsychotic treatment, even when it's clinically necessary or indicated. There were thoughts that perhaps there might be compensatory prescribing. So if it was difficult to access an antipsychotic medication, one wondered if physicians might reach to another medication instead. And there were, of course, concerns about potential adverse events. So if kids didn't have adequate access to helpful medications, would there be a spike in psychiatric hospitalizations or emergency department contacts? So the feds rolled out directives to the state requiring protocols to ensure the safe and appropriate use of these medications. And in a letter to the states that came in 2011, the letter stated that enhanced efforts to properly prescribe and monitor psychotropic medication among children in out-of-home care were necessary, appropriate, and urgent. And I just want to bring in, as I move forward, some of the actual language from these communications, so you can just get a sense of the flavor as to what is being communicated down from states, from the feds to the state, from the state to the counties, et cetera. And so with this federal directive, the Administration for Children and Families gathered with other organizations and representatives from each of the 50 states in 2012 to discuss creating and implementing integrated oversight and monitoring protocols. California, of course, was present, and from that opted to send an all-county information note. So this is now rolling down from the state level to the county level. And in that all-county information notice, they put forth a directive for a quality improvement project. And I want to highlight to you again language from that communication. They noted that social workers and probation officers with case management responsibilities, with assistance from public health nurses, are first level responders to monitor the safe and appropriate use of psychotropic medication for children in foster care. One of the directives that came in that all county information notice was a directive to use child welfare indicators. And these child welfare indicators are a series of data points that can be tracked over time. These data points many of these data points are now presently publicly available on this Berkeley website that's included here in green. The highlighted measures are the ones that are publicly available. And so you can look and see at the state level, all the way down to the county level, what percentage of kids in foster care had a claim for a psychotropic medication, what percentage had a claim for antipsychotic medication, what percentage are on multiple concurrent medications. And then also information is publicly presented about the percentage of kids who have metabolic screenings and who have ongoing metabolic monitoring. So as a result of that all county information notice and the directive from the feds, Department of Healthcare Services and the California Department of Social Services started to move forward on their quality improvement project. They gathered over 30 different stakeholders and created a series of work groups. Clinical work group, a data and technology work group, and a youth and family education work group. So all of these stakeholders were present, created work product, which then went to an expert panel for review. The clinical work group established the California guidelines for the use of psychotropic medication in children and youth in foster care. This is a document that was published in April 2015 and was revised in 2018. I'll talk about it in a moment. The Data and Technology Work Group established a data use agreement between Department of Healthcare Services and the California Department of Social Services, and then also established a global data sharing agreement between the state and the counties. And then the Youth and Family Education Work Group created a foster care youth bill of rights and a list of questions for foster kids to ask about their medications. The California guidelines document describes itself as a statement of best practice for the treatment of children and youth in out-of-home care. And this is about a 20-page document that really highlights best practices in prescribing. And then there are 4 appendices to this document. Appendix A reviews standards for the number of medications a youth should be maximally on by age group. Appendix B is a reference to a Los Angeles DMH document that reviews indications for different psychotropic medications and monitoring recommendations. And then appendices C and D are extra supports for prescribers. And then I just wanted to share with you what the Mental Health Bill of Rights looks like. It really is a document that encourages and empowers youth to ask questions about their mental health care and their psychotropic medications. So we start to see, as a result, a series of oversight efforts that we as prescribers start to notice around 2014. And the first major oversight effort was the treatment authorization request. There had actually been a treatment authorization request requirement in the state of California since 2006 for children ages 0 to 5 for antipsychotic medication. But in 2014, that TAR requirement was expanded for all Medi-Cal youth. And while much of what I'm talking about here today pertains to kids in the dependency and delinquency systems, This TAR is required for all Medi-Cal youth, regardless as to whether they're connected to the dependency system or not. So now when we prescribe antipsychotic medication, a specially trained state pharmacist reviews clinical information that's submitted to make a determination as to whether it's appropriate or not. And if we're looking to use medications off-label, there's a requirement that there's a reference to current medical literature or information from academic or professional specialists. In 2015, 2015 was actually quite a busy year for laws that pertain to psychotropic medication. We saw Senate Bill 238, requiring monthly reporting on foster children who receive psychotropic medication up to the state. It required training for important topics related to administration of psychotropic medications to basically anyone and everyone who was connected to foster kids, so group home administrators, foster parents, et cetera. And it required the Judicial Council to update the JV 220 forms. Senate Bill 319 worked to expand the authority of foster care public health nurses so that they now had a role in monitoring psychotropic medications. And Senate Bill 484 specifically pertained to group homes and set forth expectation for tracking use of psychotropic medications for children in group homes. And it wasn't just tracking, it required the state to develop measures to identify group homes with levels of psychotropic medication usage that warranted further review, and set forth group home review criteria based on psychotropic medication utilization. So for example, any one of group home facilities in the top 10% of psychotropic medication utilization gets an additional review that comes from the state. In 2016, we saw the passage of Senate Bill 1291. And to set for the stage for this, just a reminder, the county serves as a health plan for kids with Medi-Cal. And we are on an ongoing basis audited annually by the state in a process called the External Quality Review, so the EQRO. But what Senate Bill 1291 did is it set forth expectations that when we are monitored annually, that there are metrics that pertain to medication monitoring. So they specifically reference the child welfare indicators that I shared with you on an earlier slide, but they also added HEDIS measures, so healthcare effectiveness data and information set measures that related to psychotropic medications. And HEDIS measures are standardized performance measures used to evaluate health plan performance. And while there's some overlap with the child welfare indicators, there are additional measures that come under the HEDIS umbrella. Senate Bill 89 was passed in 2017, and this law mandated the state to contract with child psychiatry services to make a second opinion process available for authorization of psychotropic medications. And this, by and large, was for counties that did not have a second opinion review program. You all might know that San Diego has long had a second opinion review program available through Vista Hill. So this is not something that our county has made usage of. Senate Bill 1174 came in 2016. And leading up to passage of this law, again, kind of from all of this energy coming from federal investigations and state news articles, Senator Liu met with the Medical Board of California with the asking them to look into the inappropriate prescribing of psychotropic medication to foster kids. And the medical board historically had received very few complaints about psychotropic medication. So the board worked to identify other avenues to identify physicians who may be inappropriately prescribing. The medical board met with the Department of Healthcare Services and California Department of Social Services and developed a data use agreement. So if you remember, The data and technology was one of the elements from the quality improvement project. So that is where this kind of gets folded into the oversight process. And Senate Bill 1174 requires that the medical board receive a list of all physicians who had prescribed 3 or more psychotropic medications for 90 days or more. And I think this is just very important for us to know as prescribers working with kids in the dependency system, right? You really want to know that the medical board could have access to your name and clinical information about the kids that you're working with. So as a result of this data use agreement, I want to share a little story about kind of their first efforts, the medical board's first efforts to review care. So 86 kids were identified as being potentially prescribed inappropriately, but the data presented to the medical board didn't include kids' names. And the medical board cannot investigate without a release of information. So they essentially had this data, but no ability to do a deeper dive. The medical board requested information from, requested assistance from the state. The state worked to get releases of information, but in the end of these 86 kids, the medical board was only able to review care for 4 kids. So there was a little problem identified with 1174. So of course they passed another law in 2019, now requiring that the Judicial Council forms, that JV 220 packet, be revised to include a request for authorization, just routinely asked of all foster kids and their caregivers and attorneys, so that if a youth is prescribed 3 or more medications for a specific duration, that there already is a release of information on file. And that new form is a JV 228. There's also a JV 228 info that provides some background on why this release of information is being requested. And I just want to take some excerpts from that informational form for you all. They state the Medical Board of California will look into the care your doctor provided to you and may need more information to determine if the doctor properly prescribed medication for you. Later in this document, it states a medical expert may decide that prescribing practices involved in your care should be examined more closely. And then later, you may also allow the board to see your medical records if the board needs them to decide whether the doctor broke the law or prescribed too much psychotropic medication to you. So again, just kind of very important for us to be aware of the language that's being presented to the kids and the caregivers' attorneys involved in their care. You all know, of course, that the JV 220 is a court authorization for prescribing psychotropic medications for dependents. It was in 2016 that this document was expanded to a 6-page document required. In 2016, the process was additionally expanded to ensure that there was opportunity for feedback from protective services workers, probation officers, caretakers, CASAs, and others. And I just want to remind you all that while there is some overlap with the in questions on the JV 220, specifically regarding labs and monitoring, the information asked is not duplicative. So the child welfare indicators really drill down on a very specific time windows in which screening labs and monitoring labs should be done, but there are no questions on the JV 220 that specifically reference those time windows. And this slide is, of course, not meant for you all to read, but to just show that the JV 220, once completed, goes through literally about 13 different steps before it gets back to you all as a signed document. And you can see the JV 228 is just one added form that a protective services worker or probation officer has to collect before moving it through this process. And I wanted to remind you all that the JV220 process, while it can take several weeks to move through that 13-step process, there is a emergency treatment clause included in the law. So if you have a youth for whom medication treatment is needed in the moment, there is an ability for you to move forward and prescribe without awaiting the signed JV220. And here are the criteria for emergent prescribing. So as time moved on, the feds opted to take another look at treatment to kids in the foster care system. So the next major report that came from the Office of the Inspector General came in 2018. And this published report looked at data from prescribing and clinical care from October 2014 to 2015. So I'm really highlighting that the dates of these reports, but also the dates of when the case reviews were completed, because as you can see, 2014 to 2015, was just very much at the beginning phases, for example, of when California was moving forward with oversight and monitoring efforts. And continued quality of care concerns came in this federal oversight. So this document had highlighted that kids were not getting treatment planning, medication monitoring. A 2019 report looked at ADHD medication trends, highlighting that kids were not getting follow-up care within a specified window after being prescribed ADHD medications. Kids were not getting behavioral therapies. And legislative changes continue to develop. So in 2021, we have a sponsored bill really spearheaded by our Cal ACAP organization that will require the creation of electronic healthcare portal so that we as healthcare providers will have much easier access to health information. So thank you to Cal ACAP for that. And I pointed out earlier that when all of these efforts for oversight were rolled out, there was little known about the effectiveness on the targeted outcomes, and little was known about the unintended consequences. But there's now literature emerging to review these system-wide interventions. And a January 21 article in our own Orange Journal did a review of system-wide interventions. So the first type of intervention that it highlighted was prior authorization. It looked at studies from 10 prior authorization programs, and it highlighted that prior authorization programs often are associated with a significant reduction in antipsychotic medication use for the age group targeted by the respective prior authorization program. And this is a graphic from that newspaper article from the San Jose Mercury News. And this frequently is used to highlight that California's treatment authorization request was effective in reducing the number of kids prescribed antipsychotic medications. I always like to bring up in groups that a lot changed between 2013, 2014, and 2016, 2017 that also could have had an impact on provision of antipsychotic medications to this population. It was during that time that the DSM-5 came out, child welfare numbers were dropping, and we also had a collective increase in knowledge about side effects stemming from second-generation antipsychotics. But I think you can also see that kids prescribed multiple antipsychotic medications dramatically dropped during that time period. The second major classification of antipsychotic medication is clinician prescribing enhancements, or essentially prescriber education. And the Orange Journal article highlighted that at least there's a short-term effect with clinician prescribing enhancements on the primary outcomes that were assessed. So here in San Diego, we've worked to have a number of clinician prescribing enhancements, the first of which is our medication monitoring tool. So kids in our system of care We have quarterly peer reviews called medication monitoring. And I've worked to update that document to include questions that align with the California guidelines and with the child welfare indicators. And I included a narrative on that document with the various links to the California guidelines document, just to serve as an ongoing reminder to you all about why we're asking these questions, and so you can have easy access to the document should you want to review it. And here in San Diego, we've opted to use this document for all kids, not just kids connected to child welfare and probation. So again, while the California guidelines document pertains to a subset of foster kids, we use their recommendations to review the care of all kids in our community. Another example of clinician education, we have, of course, the Vista Hill Juvenile Court Clinic. They are available to do reviews of each and every JV 220 for the juvenile court, and they provide feedback to the prescriber when there's prescribing that maybe goes outside the guideline, what was set forward in the guidelines. The Vista Hill Juvenile Court Clinic is also available to provide second opinions on any kid in our system of care, regardless as to whether they're connected to the dependency or delinquency system or not. And the Vista Hill Juvenile Court Clinic is available to provide additional trainings to prescribers on JV 220s, psychotropic medication oversight. So if any of you have a desire to get additional information on this or want additional information disseminated to peers or others that you work with, Vista Hill and I are both available to provide that information to you all on an ongoing basis. And finally, we have the Barrier Buster meeting series, and I have to credit my mentor, Dr. Rowe, for creating this. This is a multidisciplinary case review meeting series for complex youth, where we often bring in system partners like child welfare, probation, school districts, regional center. So if you have a youth for whom you are feel like that youth is particularly complex, you want to make sure that they have maximum supports from the different agencies, you are welcome to bring those cases forward for additional support. Another type of oversight intervention is delivery system enhancement. Delivery system enhancement really focuses on coordinated care through team-based, child-centered, family-focused services. And I just use this slide as a placeholder to share that, our system of care, our children's system of care, by and large, works to bring in multidisciplinary care. So our services range from outpatient programs all the way up to inpatient psychiatry services. Our outpatient programs are all full service partnerships. So we have clinicians available to do individual and family therapy. Each program has additional support partners that may be case managers, parent support, peer support, substance use disorder counselors, in addition to child psychiatry, to really ensure that that multidisciplinary care is available to the kids. Some of you may be working outside our children's system of care. And if your system, whether that be a private practice, an FQHC, if you're working to support a complex foster child and you feel your system does not have that multidisciplinary care available, please do not hesitate to refer that youth to our system of care. We really are dedicated to serving complex kids as a specialty mental health care provider and have a strong partnership with child welfare. Child welfare itself has also transitioned over time to include multidisciplinary involvement. So I just want to rewind and talk to you briefly about the KDA lawsuit, which resulted in the Pathways to Wellbeing program. KDA was a youth who had a significant trauma history and ultimately touched like upwards of 20 different group homes, foster homes, psychiatric hospital, and at no time really received adequate assessment and treatment services because of her frequent moves through the system. And a class action lawsuit was filed on her behalf that led to substantive changes in the child welfare system. And as a result, all kids coming into the dependency system are now screened kind of at the front end, and the vast majority are referred for treatment services. The hallmark of this change included the development of a child and family team. And so this child and family team is when the child and family gathers with representatives from child welfare and behavioral health services to talk about challenges faced and care provided. And while we as physicians may not be represented at the child and family team due to scheduling and other logistical issues, if you are working within our children's system of care, there will be representatives from our program who are available to attend the child and family team. Another enhancement available now is through the public health nurse program. As you recall, there was a legislative change in 2015, Senate Bill 319, that required public health nurses to be involved in the monitoring of psychotropic medications. Here locally, our first efforts with public health nurses was for them to work to ensure that all foster youth prescribed psychotropic medications had an active JV220. And this was not problematic by and large for kids receiving psychotropic medications from child and adolescent psychiatrists. I feel like JV220s are our bread and butter, and we know that they're required and we know how to manage them. But we really identified kids prescribed by pediatricians, neurologists, et cetera, who may have, those prescribers may not have large populations of foster kids and may have missed the JV220. Along with child welfare, public health also worked to provide education around the JV220 process to community members. And presently, public health, child welfare, and I are doing an ongoing deep dive into individual cases to explore reasons why metabolic monitoring and screening, why there have been challenges for prescribers to complete those screening and monitoring recommendations. So with all of this being said, I wanted to just review, this is data that comes from that Orange Journal article that I referenced. It's a 2021 article, the ongoing trends in usage of psychotropic medications. So antipsychotic medications are still, usage is still substantially higher in the US as compared to other developed countries. And while there is a strong evidence for antipsychotic medication in youth with primary psychotic disorders, the vast majority of usage is still for non-psychotic disorders or conditions lacking approval by the FDA, typically ADHD and other externalizing conditions. So the top target symptoms include aggression, irritability, impulsivity, with only about 5% of the antipsychotic usage coming for kids with psychotic symptoms themselves. In summary, systems are evolving. So in this 20-25 year narrative that I've presented, you've seen that there have been major diagnostic changes, the role of child welfare in society, and in how they support the kids that their target population has changed. Scientific literature has transitioned, and there's emerging treatment practices and modalities. But I just wanted to highlight that there are supports available through multidisciplinary care and a variety of types of system supports available to you as you move forward in taking care of these kids. We really appreciate the dedication to the kids that you serve. Finally, I have a series of slides with data from the Child Welfare Indicators Project. And I'll just take a couple of minutes so you can start to see some of the numbers and how they're changing. First, I want to highlight that the number of kids in foster care rapidly declined between about 2003 and the early 2010s. But if you look at the blue line across the bottom, the number of kids authorized for psychotropic medications has largely remained the same over that period of time. So while the number of kids in child welfare has gone down significantly, the number of kids on psychotropic medications has not changed. And if you take a look at the percentage of kids on psychotropic medications, you can see in approximately a 10-year period, the percentages of kids on psychotropic medications has not dramatically decreased over that period of time. So recall that that dramatic decrease came pre-2011, and now I'm showing you that numbers that are available through the Berkeley website, and those numbers only are available from 2011 moving forward. So for that time period, psychotropic medication usage has not dropped dramatically, but the percentage of kids on antipsychotic medication has decreased significantly over that window of time. The percentage of kids on 2 or more medications has stayed about the same, but the percentage of kids on 2 or more concurrent antipsychotic medications has dropped significantly. And here in San Diego, our numbers are so small that they're not even really reported. The percentage of kids with metabolic monitoring, the data, our numbers are not great, and they have not gotten better with time. So only approximately half of kids have ongoing metabolic monitoring. And the percentage of kids with metabolic screening labs within the window of time recommended is only about a quarter of kids. San Diego data is not specifically available because the N is very small. And that is it. I can go ahead and take questions now. I don't know. Anna, are you able to transition?
Yeah, so you can just click stop sharing screen. We do have a comment in the chat from Dr. Rowe. He said, this oversight may seem overkill. The problem courts and legislators are trying to solve is that foster children usually do not have a parent who is responsible to ensure the child's safety during the prescribing process. So all of the forms, oversight, reviews are a way to provide the same protection that a parent could or should provide during the process. Foster parents are not permitted to play this role. Biological parents are not permitted to play this role unless the court makes a finding that they may. So I just wanted to acknowledge his comment in the chat. I don't know, Dr. V, if you want to touch on that, or if anybody has any other questions that you could send through the chat or unmute yourself. We have a couple of minutes for that.
Yeah, I think there's been so much energy and effort that's been honed in on psychotropic medications, when in reality there has been a need for changes in the system. And I think, again, with KDA, congregate care reform, child and family teams, we're seeing some of those substantive changes that are coming concurrently with all of this energy around psychotropic medication oversight.
Thank you, Dr. V. We have another comment in the chat. I heard that Cal CAP, I'm not sure if I'm saying that right, is working on a policy proposal for improved communication between CAP providers and the court. Can you talk more on that?
Yes, absolutely. So that is the proposed bill moving through the legislative process, where Cal ACAP has requested that prescribers have access to an online portal with important health information. So what that portal would include would be things like the health and information passport, prior JV220s, and other health information, so that as prescribers, when we have a foster care youth sitting in our office, we can log on and see that information easily, as opposed to trying to pull all of that information from, parents, caregivers, protective services workers, et cetera.
Thank you, Dr. V. We have a from Michelle Lozano. She says, is there a way to address the 90 days on 3 meds recommendation?
Michelle, tell me what you mean by address.
Hi, Laura.
Hi.
Good to see you. If the guideline is not to be on more than 3 medications for 3 months, and obviously most of our youth are on a medication longer than 30 or 90 days. What are they kind of looking for in terms of, do they want us to try and taper a med off? Do they want us to, I mean, 3 months is not a lot of time.
Yeah, so here in San Diego, we have used the guidelines just as that. They're guidelines, but they're not mandates. Ultimately, we want, you all are trained professionals working with these kids. We want you all to feel empowered to make medication decisions for the children's well-being. I think it's important to have this menu of information behind you and under your belt, but ultimately it is your clinical judgment. I think what's really important is to know that if you believe that a youth needs medications, for, a greater number of medications for a greater period of time, I, as a prescriber, would want to know that my medical records might be going to the Medical Board of California and I would definitely make sure my documentation is organized in such a way that a medical board reviewer would say, yep, this prescriber is thinking about kind of all of these nuances and they're on top of it. So as an example, I might put in the narrative, optimally, this child would be on fewer than 3 medications, but here are the clinical reasons that I've opted to continue these medications at these dosages at this time. I have worked to pull in multidisciplinary care in this way to ensure that there are maximal supports for this youth. And then I might even add things like, I have shared the foster care bill of rights with the child. I have shared with them that, there might be, there might be a review of their medical record. I think if there are kids who are complex where you feel in any way uncomfortable, you can request a barrier buster or request a second review by a second opinion review by Vista Hill Juvenile Court Clinic. And then you can document in that in your note and say, I brought it for a second opinion and this was the feedback I received. So again, in no way, shape, or form are we trying to dictate your prescribing. And I do think there will be, cases, where kids are on more than 3 medications for over 90 days. But I think you just want to inform your documentation.
Thank you, Laura. I was working in between when we switched over in 2015. I feel like it was like, I still remember October 1st for some reason, but maybe that was the changeover from ICD-4 to 5. But I appreciate Cal ACAP's contribution to this, but it just is frustrating when like a pharmacist is reviewing your TAR and it gets denied, and so it's just frustrating.
All right, I want to be mindful of time. We are at 10 o'clock. We do have a couple more questions in the chat. For anybody that wants to stay, you can go ahead and stay, or if you want to sign out now, that's okay. I'm going to go send the post test in the chat. Make sure you complete that by the end of the day tomorrow, so by 4:30 p.m. In order to receive full credit. Like I said, whoever would like to sign off now, thank you so much for joining us today. Thank you, Dr. V. And Dr. V, if you would like to answer a couple more questions in the chat.
Absolutely. So Meg, I see your question about getting access to labs. I think, just to set the stage, I think one of the reasons that metabolic screening and monitoring levels appear so low is that at times labs are being done in hospitals or detention facilities, and those labs are not being billed to Medi-Cal directly. So when they pull, the data is all based on claims data. And if, there's no claim going in, it doesn't, show up that these labs are being done. I think, getting labs from inpatient hospital stays is, just involved in getting the records released and, making a request for that information. I know oftentimes you get a discharge summary and so you're not able to get the labs. Perhaps we can work with our local inpatient teams, and I would hope we can, at a minimum, work with Radies to make sure that those can be distributed to you all as part of an aftercare summary, as part of the warm handoff. But I see Neha's comment that ideally, if we could get this into the health portal, that would be optimal. Is there a way to receive the JV 223 faster? I will tell you that we have had work groups to try and move things more quickly through the JV 220 process, all those 13 steps. I don't know that we're going to get substantively faster on moving through those steps. What I can share with you is an encouragement to look at those emergency prescribing criteria, and just let you know that, I would make sure if you were emergently prescribing, you would document in the spirit of those, but we're not on an ongoing basis, looking at every emergent prescribing episode and saying, oh yes, that met criteria, and oh no, this didn't meet criteria. So I would consider using that liberally, particularly if you have kids with functional impairment. When might the portal be active? The law is still, they're still moving through and doing revisions of that Senate bill. So it's going to be a year. Not this calendar year, certainly, likely a couple, 2 to 3 years for the portal. How long does it take get data back from the state? Forever. No data moves quickly. Always the data we're looking at is quite old. You can see in these last set of slides that I presented, the most up-to-date data that was available to me was from March 2020, so a good year old. I see struggles getting discharge summaries. Some of the PSWs don't forward the JV 223 to the doctors and don't return calls. Joan, please keep my contact information and alert me when you have problems. Child welfare has included in their policy that the PSWs are supposed to send the 223 back to the physician. I know that that's not always happening. When you have trouble getting in touch with a PSW, I always encourage you to elevate it to their supervisor. County is very hierarchical. If somebody's not attending to your needs, ask for their supervisor, or you can always loop me in. It's always helpful when I'm looped in because oftentimes your problem is a representative of a system problem. And if I know that these challenges exist, I can work to address them on a systems level. Are you able to send out an easier to read version of the flowchart? Yes, of course, I can send that. That is, Dr. Rowe created that for our system. And I am, with his permission, I will happily send that out. Dr. Rowe, do you have a question or a comment?
I do. Laura, do you get the med monitoring compilation?
Yes.
So you can say how our system stacks up in terms of us complying with the criteria?
Yeah, so we review about 1% of cases on a quarterly basis. And by and large, when the charts move through the process, there's very few findings, if you will. But I will say the labs are a challenge. And so as part of our next effort, we did a deep dive, literally looking at EPIC records and CCBH records for each and every kid who had a JV220 for antipsychotic medication, so that we can get a better understanding as to why kids are not getting screening and ongoing monitoring labs, so we can see how as a system we can affect change and support physicians and kids and their families in getting labs. So I would say the labs are the biggest challenge for our system.
All right, thank you so much, Dr. V. I know we're 6 minutes over. Thank you all for staying, for those of you that stayed. And thank you, Dr. Rowe, as well. Your certificate of completion will be able to download through the RISE LMS through your account. If you have any questions with that, you can just go ahead and send me an email. Since I know I registered some of you, and it'll take approximately 5 business days. So again, thank you all for joining. Thank you, Dr. V, for putting on this wonderful presentation. I hope you all have a great day. Thank you so much.
Thanks so much.